This presentation is provided by Dr. David Sack, a professor in the Department of International Health at the Johns Hopkins Bloomberg School of Public Health in Baltimore, Maryland, in the United States. The presentation is based on many years of experience when using these rapid tests in surveillance systems in countries in Africa and Asia. The goals of the presentation are listed on this slide. After studying these slides, we believe you should know the basic principles of the test so you will understand how the test works. Next, we want you to be able to safely perform the test with a stool sample of a patient suspected of having cholera. If the result of the test is positive, we want you to be able to confirm this result to make sure it is not a false positive result. We will show you how to rule out false positives later in the presentation. Please note that RDTs can also be used to detect Vibrio cholerae from wastewater, but this will be explained in a different presentation. As shown in the figure, the RDT dipstick has 3 potential lines. The upper line is the control line and is included to be sure the test is working properly. If there is Vibrio cholerae 01 in the stool sample, the second line will also be visible. The test actually detects the lipopolysaccharide, or LPS, of V. cholerae 01, so it is specific for this serotype. It will be positive if the concentration of these bacteria is very large, but if the number of bacteria is low, the sample might contain V. cholerae, but the result will be negative. The limit of detection is about 10 to the power of 7 colony-forming units per milliliter. The third line was included in the test to detect another serotype, 0139. This other serotype was the cause of an outbreak 20 to 30 years ago, but it has now disappeared, and it never appeared in Africa. However, the RDTs we now have available continue to have the line for 0139. We feel that the test would be better if the line for 0139 is not included, and we anticipate that a new RDT may become available that will have only the 01 line. Unfortunately, the 0139 line sometimes gives false positive reactions, but these are due to some cross-reacting materials that are not cholera. For now, we recommend that one ignore any line for 0139. We do not know why the line for 0139 line appears, but in recent years, it has always been a false positive. Recall that the test detects the LPS of the bacteria, so it does not matter if the bacteria are alive or dead. If there is enough LPS in the sample, the test will turn positive. Direct testing. A sample for cholera starts with a proper fecal sample, so a stool sample needs to be tested, not a rectal swab. We define a direct test as one in which the stool sample is tested directly with the RDT. With this method, the result is available in about 15 minutes. The other type of test is the enriched test, in which the fecal sample is incubated in alkaline peptone water, or APW, for 6 to 18 hours before it is tested using the RDT. We will discuss the enriched test later, but these initial slides focus on the direct test. The use of rectal swabs for doing the direct RDT sometimes works, but this has not been validated and is not as sensitive since the number of bacteria may be less than can be detected. The container for collecting the stool sample does not need to be sterile, but it should be clean. It can be cardboard or plastic, and it should not have any bleach or disinfectant, since the sample may also be sent for culture, and this would kill the bacteria, invalidating the culture result. Be sure to label the sample with the patient identification. The lab may assign a new lab ID. If the lab assigned a new number, be sure there is a link between the 2 identifications. The kit comes in a small box. Inside the box are these supplies. Often, there are supplies for 10 tests in the same box. The supplies include the dipstick in a foil packet, some test tubes, the buffer vial, a rack for the test tubes, and a pipette, along with the instructions. If there are questions about performing the test, the instructions are very clearly written and can help. In addition to the supplies in the kit, one should also have PPE, gloves, and bleach, since you will be handling potentially infectious materials. The optional supplies include Carrie Blair transport media in case the samples are to be sent for culture and need to be transported to a lab. If the lab is located at the same facility, the stool sample can be sent directly to the lab for culture. The alkaline peptone water will be needed if one also does the enrichment test, as discussed later. To carry out the test, one needs a small space where you can organize your work. Be sure to examine the test materials to be sure they have not expired. The kit is normally stored at room temperature, and the test should be carried out when it is at room temperature. The area where the test is done should be clean and disinfected, and the person doing the test should wear PPE and gloves. Once you are ready, the test procedures can begin. Start by labeling the buffer vial and opening the lid of the buffer vial. One then adds the fecal sample to the buffer vial. If the sample is liquid, add 2 drops of the liquid diarrhea sample to the buffer vial, but if the sample is semi-solid, a small amount of stool is added. Now that the stool is added to the buffer vial, close the lid and shake the vial to mix it well. After the stool is well mixed with the buffer, break the cap off the buffer vial. The buffer vial now becomes a dropper bottle, and one uses this dropper bottle to add 4 drops from the buffer vial to a test tube. Place the test tube in the foam rack to stabilize it. It is now ready for testing. To do the test, open the dipstick foil wrapper and label the dipstick with the patient ID. Then, place the dipstick into the test tube with the liquid at the bottom of the tube. Leave the dipstick in the tube and place the test tube in the foam test tube rack for 15 minutes before reading the result. These photos show the same steps as were illustrated on the previous slides. Either this slide or the previous slides may be printed and used as a poster to show the steps in the test. After 15 minutes, it is time to read the results. The instructions indicate 15 to 30 minutes, but in general, the results are clear within 15 minutes. Do not read the results at a later time. When reading the results, first confirm that the test is valid. To be valid, the control line should be visible. If you see only the control line, then the test is read as negative. But if both the control line and the O1 line is seen, then the test is read as positive. If the control line is not seen, then the test is not valid and needs to be repeated, even if the O1 line is visible. This slide shows some examples of possible valid tests that we have observed. The most common are examples 2 and 3, which can be read clearly as either negative or positive for V. Cholerae O1. Examples 4 and 5 are more confusing because a line is seen for O139, but in our experience, lines for O139 are always falsely positive. Example 4 can be read as negative, but example 5 shows lines for both O1 and O139. In this case, the test should be read as positive, but will need to be confirmed with a confirmatory test. When the results are read, these results should be recorded and placed in the patient's chart or clinical record. They also need to be included in the National Surveillance System database. Increasingly, this is done through an electronic data system, but in some systems, it is recorded on paper and is passed to another staff member who incorporates the results into the report to the ministry's data system. After the RDT is read and reported, the result needs to be interpreted in light of the epidemiological situation. Recall that these RDTs have been found to have high sensitivity and high specificity. However, no test is 100% accurate all the time. An isolated case of cholera is extremely rare, so any such isolated case needs to be confirmed, preferably with a culture and PCR. During an outbreak, the tests are used to monitor the course of the outbreak. Depending on the national policies, only some of the positive tests need to be sent for confirmation, since one is less concerned with false positive tests when there are many cholera cases occurring and the positive predictive value is very high. The RDT is, however, helpful in determining which samples should be sent for culture to confirm antibiotic sensitivity tests. The national guidelines will provide more specific guidance on what proportion of the samples should be sent for culture and confirmation. In areas with low prevalence, the RDTs may seem less reliable. This is because, with low prevalence, the positive predictive value is lower, meaning that a higher proportion of the positive results will be false positives. In the setting with low prevalence, we recommend confirming all positive samples with a confirmatory test, and we will describe the confirmatory tests in the next few slides. There are 3 ways to confirm an RDT result. We stress that these methods are especially useful to confirm positive results to rule out a false positive RDT result. But each of these confirmatory methods can also be used if the RDT is negative when the clinical presentation strongly suggests cholera. The tests include the enriched RDT, culture, and PCR. The enriched RDT is done by inoculating the fecal sample into alkaline peptone water and incubating the APW for 6 to 18 hours. When this is done, the cross-reacting materials in the sample are diluted in the APW and will be less likely to cause a false positive reaction. At the same time, the V. cholerae, if present, will be amplified by the incubation in this selective media and should give a stronger RDT result. After incubation in APW, 4 drops of the APW are added to the test tube, and dipstick is placed in the tube, as was done the direct test. One does not need to use the buffer solution when doing the enriched test. Note that one can use RDTs with rectal swabs when using the enriched test, since the APW will amplify the Vibrios sufficiently to be detectable in the RDT. Sending a sample for culture is already a routine procedure for most surveillance systems, so there is no need for detailed instructions. However, we show these photos to remind you of this method. Recall that the sample sent for culture is generally the stool sample or rectal swab, but one can also inoculate the APW after incubation into Carrie-Blair to send for culture. One can also send samples for PCR, and the easiest way to do this is to use the RDT dipstick as the collecting matrix for the bacterial DNA. When one inserts the dipstick into the fecal sample, bacterial DNA sticks to the RDT, especially to the wick, bottom of the dipstick. Thus, after one has read the result of the RDT, one can then place the dipstick back into the foil, along with the desiccant, and send it to the PCR lab. Remember to label the dipstick and the foil packet with the lab ID. The foil packet should be put in a plastic baggie and sent to the lab. There is no need to refrigerate the sample. It is stable at room temperature for many months. In the lab, the DNA will be extracted from the dipstick and tested for V. cholerae by PCR. We trust you have enjoyed learning about the use of rapid diagnostic tests for cholera. If you find this presentation useful, please let us know. If you come across any details that are misleading or could be explained better, kindly notify us about these as well. We believe that better surveillance with the systematic use of RDTs will greatly help in the control and eventual elimination of cholera as a public health threat in many, if not most, countries that are now threatened by this pandemic disease.